Good morning, everybody, and welcome to today's webinar on how we can tackle COVID-19 coronavirus with people who are experiencing homelessness and particularly those who are rough sleeping. Today, we're joined by Dr. Al Story from the NHS in London, who will talk about the approach and the system that they're using to support people who are rough sleeping and be treated if they have COVID-19, and also to talk a little bit about prevention. Very quickly, before I hand over to Al, I just want to do a quick recap on what we're doing. So, as I mentioned, here is today's webinar topic. A reminder that the webinar is being recorded, and we will send out a copy of the recording along with the presentation afterwards. And if there are resources or things that Al are talking about during the webinar, we'll attach those so you can get them as well as part of the follow-up. Quick reminder that this is simply one webinar in an overall series that we've been running since lockdown has started on everything from self-care, motivational interviewing, child abuse, domestic violence, trauma, self-harm. All of our previous webinars are available to watch back on our website, and we'll send around a link after this webinar where we have 2 left on gambling and homelessness and building trusting relationships with clients, and we will share the link to register for those if you would like to join us. And finally, a quick reminder that in the last year, Fianza has changed their membership structures. Previously, to be a member of Fianza, you have to be a national level homeless service. Now we accept homeless services at local, regional level also, but we have broadened beyond just homeless services. We have cities, we have ministries, we have agencies, think tanks, foundations, and a whole range of actors and stakeholders, because preventing and ending homelessness requires a broader collective. So I'm going to hand over to Dr. Al Story now. He can share his screen, and hopefully Al, you can bring up your presentation. And I just want to remind participants, as Al is setting up, that we have a questions box on your admin screens on the right-hand side of each participant's screen. If you have any questions that you want to ask, if you have clarifications, or if you'd like a bit more information, feel free to put those questions into the box. And at the end of the presentation, we can have a conversation with Al. So please feel free to ask questions in the box.
Just trying to minimize the thing. Sorry, folks.
No problem.
How's that?
Perfect. Great. Excellent. We can see the presentation.
Okay. Yeah.
Okay.
Fine.
Thanks, Al.
Well, hello, everybody, and thank you very much for the invite. What strange times. Sorry, I've got a bit of a COVID cough. So I'm just going to share with you what's happened in London over the last rather tumultuous months, and hopefully stimulate a little bit of debate. Very happy to take questions afterwards, and hopefully kindle some ideas in terms of how we might collaborate and perhaps even share some data going forward. But first, a tiny little bit about me. I'm clinical for the main, and I run a pan-London service called Find and Treat, which is a street outreach service, which is principally dedicated to the control of communicable diseases and the broader health needs of homeless people in London. We also work nationally supporting Public Health England in incident and outbreak management. But my other job is I co-direct the Collaborative Centre for Inclusion Health at UCL with my colleague Andrew Hayward, and I'll just share with you a little bit of data that we've sort of pulled together over the years. So we've published this. It was the first really complete systematic review of morbidity and mortality in homeless people and inclusion health populations, and you can have the slides, so do feel free to follow up on any of these references. But I mean, the thing that came out of this was really a staggering insight into what the differential mortality effect was in terms of standardized mortality rates. If you look at the UK population, and split them up by indices of deprivation, usually divided into IMD 1 to 5. So the richest population usually are faring much better than the poorest population for every health condition. And also in terms of life expectancy, we see about a twofold risk in terms of increased risk of premature death between the poorest and the richest. But if we add to the same graph the homeless population, we're actually seeing a phenomenal elevation of premature mortality, risk of premature mortality, and in men it's 8 and in women it's 12. So we know that every health condition on the planet has a differential attack rate, and that is really determined by poverty and exclusion. And we were acutely aware of the fact that COVID was likely to have the same impact in terms of the homeless population, particularly in London. So, I mean, another thing that came out rather early was the recognition that from a clinical perspective, people who have got clinical risk criteria that would make them eligible for influenza vaccination are at far higher risk of very severe illness and death associated with COVID. And we've done a piece of work a number of years ago looking at eligibility for influenza vaccination based upon these clinical risk criteria. And we knew that over 40% of the homeless population in the UK were in fact eligible for flu vaccination based on existing comorbidities, principally obstructive airways disease, cardiovascular risk factors, etc. So the chronic diseases. So a huge burden of comorbidity in this population that was definitely going to put them at a massively increased risk from COVID-19. This is our wonderful Prime Minister, and the news came pretty late in the UK. We were quite late to lock down, but this was basically a blanket announcement. It was announced on, I think, the 23rd of March, which was late because we'd already started preparations for trying to mitigate risk from COVID in the homeless population on about March the 12th, 13th, and I'll just talk you through a few of those interventions, as it were. But I think it's really important to sort of frame this entire conversation within the context of home. I mean, home has demonstrated itself to be the most effective preventative treatment, in inverted commas. It's the most powerful medicine available for COVID. And a very clear political statement such as this, which was made across the world, was really drawing into very sharp focus the issue of, well, what about people who don't have a home? And there was very little national planning, and still is a bit of a void in terms of national planning, in terms of how to support people who are homeless. So we tried to fill that vacuum by developing guidance very early on, and that guidance was taken up by London. But I mean, let's be warts and all in terms of the politics of this. It was blocked as a national guideline because it basically made what was happening in our nursing homes look an embarrassment to the government, where they'd been very, very late in providing any sensible guidance to actually reduce risk of transmission. So unfortunately, the guideline wasn't published, but it is published and was adopted by London. So a few meetings occurred where we basically tried to highlight the fact that not only was there a staggering risk of increased mortality, but there was also a lot of vacant property across the city. There were thousands of empty hotel rooms. And so the GLA in London, the Greater London Authority, they stepped up to the plate and they began to contract multiple hotels to actually start to try and get people off the streets and out of these communal night shelters. And this announcement led to an absolutely unprecedented event in that thousands and thousands of people came off the streets and into their own room accommodation. So, I mean, you can all read, but this is in a nutshell what the plan was. We rapidly established a coordination centre, and the first priority was to close the night shelters and the crowded day centres, where it was very clear that this communal airspace would result in very, very high risk of transmission. And we just didn't want to take people out of these day centres and off the street and put them into hotels. We wanted to be meticulous in triaging the population for any evidence of disease. At that time, we were working with symptom screening because there was no testing available in the UK, certainly not for this population anyway. And so we were dealing with a pretty non-predictive clinical algorithm, looking at new worsening cough, looking at fever self-reported or measured at 37.8 or above. And we more recently added a change in your sense of smell or taste. But that wasn't a perfect tool, but nevertheless, it was it's certainly better than nothing in terms of identifying people who were symptomatic and likely to be infectious and separating them from the population more broadly. We closed down all the communal areas in the hostels and hotels that were used to house the street population. And working in partnership with many of the charities across London, we initiated daily symptom screening, a lot of infection prevention control advice, and we actually connected every single one of the facilities that we were aware of to an active surveillance system that enabled the non-clinical frontline workers to report people who were symptomatic. And as of 1st of April, when we got hold of testing, we've scaled an outreach testing model that I'll share with you. And we also established, in partnership with MSF, a specific clinical facility to accommodate people who had COVID, homeless people who had COVID. So, I mean, the first thing we did really was to get a definitive map of where everybody was and where they were going. We established this as a digital platform for the sector to basically feed into and complete a very simple baseline survey. And that survey was really designed to get some information about what the risk was in terms of, the number of people who were still in shared rooms, lots of people who were still obviously sharing bathrooms. And we were promoting throughout this idea that, the only really effective intervention is a single room, your own door, and your own bathroom. And so we very rapidly were able to pull together some quite comprehensive data on what the situation was like on the ground in terms of the access to PPE, in terms of closing down communal areas, shared bathroom facilities, etc., etc. And that enabled us to target certain control interventions at those facilities that were still accommodating people in shared airspace. Sorry, some of these slides are a bit small. I hope you can see it okay. But we got over 100 where we got nearly 160 different venues to complete this baseline survey, and then engage in regular reporting. So rather than just waiting for people to be grossly unwell and perhaps present to hospital, we started to ask the non-clinical workers. We trained the non-clinical workers. Many of them we gave tools to, pulse oximeters, thermometers, etc. And we asked them to do daily symptom screens on people and report to us anybody who was experiencing symptoms with a view to outreaching testing very rapidly. The testing on its own is not sufficient. There's also been a very clear evidence internationally about the importance of trying to contact screen around new cases. And we found, we knew really from the work we've done with tuberculosis for many, many years, that the contact screening really breaks down once you take a pathogen out of a traditional household setting and you unleash it on a far more socially complex community. The sort of main principles that underpin the success of contact tracing, they break down in the homeless population. So we proposed a very different model. The national approach is still very much built on this in the UK. You recognise your own symptoms, you self-isolate while you're symptomatic, you report your illness online, you get a testing swab kit sent out, or you go to a testing center, and then you download some app which basically enables you to enter your contacts, and they are then contacted and also advised to stay at home. I mean, this is obviously not going to work for homeless people. So we were very strong quite early on in advocating for an outreach-based model where we were literally going to take a testing service and a same-day contact screening service to anybody who was reporting symptoms. And the key to making that work was very much rooted in every other element of our work, and that is it's very service user led. About half of our team are people who have got experience of homelessness, and we in fact provided most of the testing through non-clinical peers. So I mean the actual nasopharyngeal swabs and throat swabs were done by peers, and the PPE training was provided by peers. So it's one of the reasons why we got such good engagement, was just applying those sort of simple principles of peer engagement. So just share with you a little bit of the early data. So as I say, we were very late in getting access to testing. We've tested over nearly 1,500 people so far, but this gives you data from the first few weeks, from the first sort of 800 or so we did. So relatively small numbers initially, and quite a high detection rate initially in both the hotels and the hospitals. But it was quite clear to us, again, the etiology of this pathogen is almost unknown. You'll have seen recent WHO announcements, in terms of risk of asymptomatic transmission. Well, we were, sorry, my lungs are still a bit COVIDed out. We saw data from the our American colleagues quite early on, was shared with us from particularly colleagues in Boston, where they'd done a number of quite large screening events in encampments and in shelters, but particularly the data from the shelters was really worrying, because they were finding very high rates of infection and very high rates of asymptomatic carriage. So we were acutely concerned that there was perhaps a risk of asymptomatic carriage in population as well. So we undertook a couple of quite large screening events in some of the bigger hotels, and consistently found a asymptomatic carriage rate of between 3 and 4%. So much lower than our American colleagues were finding. And this really informed our approach going forward, where we're now using a combination of targeted outreach testing, contact screening around that individual real time there and then, coupled with sentinel screening of some of the larger venues on an ongoing basis to monitor this asymptomatic carriage rate. Now, the other thing we did was set up convert a hotel into pretty much a small hospital. It was a hotel near City Airport. It was a very cheap budget hotel. There was no soft furnishings. It was very easy to clean, and we set it up as a proper isolation unit. Now, I had completely deployed every single one of our team, and there was very few healthcare workers available at this time. So we actually asked Maisons Sans Frontières to step in and help out, and it was the first time they'd ever deployed in the UK. And they did a phenomenal job working in partnership with Find and Treat to open this centre within 24 hours. We were operational. And we took people who were confirmed COVID out of hospital. We took people who were query COVID from the streets. We took anybody who was symptomatic from the hotels and the other hostels. And so we were very rapidly able to isolate people who presented a significant transmission risk to others. And the duration of stay here was really 14 days from the onset of your symptoms. And, it wasn't so much just the isolation agenda, it was also clinically monitoring people, because as many of you will be aware, I mean, this nasty bug seems to come in two phases, where you get quite an acute illness early on, and then it sort of plateaus, and then unfortunately quite a high proportion of people, particularly those with comorbidities, they deteriorate in the second week due to this awful inflammatory lung response, and that's where a significant proportion of the mortality was occurring. So we were doing quite careful clinical observations on people in COVID care and escalating them to secondary care for intensive life support as required. That was only required for 2, in fact. So just let's look over the Atlantic at some of the experience from the States. So we're working quite closely with colleagues in the US for a number of years, and just share with you a couple of sort of features of their response. Well, first and foremost, the street population in the US is just eye-wateringly massive. I mean, this photograph is surreal. It's basically people being allocated a parking spot almost. This is social distancing for the street population. This was in fact in Las Vegas, but this happened in many areas of the state. People being asked to sleep in a parking space. That was a bit nuts. CDC, Centers for Disease Control and Prevention, they issued some guidance quite early on, and they were encouraging sort of strict social distancing, separating the beds, introducing screens between sleeping spaces. They had access to far more testing capacity than we did, so they were testing right from the beginning and doing regular symptom screening. They said they were going to move people who are symptomatic or the most vulnerable into alternative accommodation. That didn't happen much, according to our intelligence, but they did do a lot of work to obviously clean facilities, minimize sharing of bathrooms. But what they did not do is close down the communal shelters, which is the mainstay of sort of provision for the homeless population in the US. The shelters remained open. And some of the guidance that came out relevant to these shelters was, almost Dickensian. They were recommending people, even with respiratory symptoms of COVID, were recommended to sleep, head to toe. This was obviously a pretty desperate attempt to minimise transmission risk. So whilst we'd opted for a own room with own bathroom as a minimum standard, as I say, the Americans and many other countries continue to allow the communal shelters and sleeping spaces to remain open. And this is pretty much the sort of norm in the States and in many places. So this is a masterclass in how not to prepare a PowerPoint slide because it's way too small, but I was aware of the fact that you get to keep these. So, as part of my obsession with this particular response, I've been trying to collect data on numbers of people diagnosed with COVID in homeless cohorts across the world, particularly in the States. And most of these link to not scientific articles, but to news reports. But as you can see, I hope it's not too small. I mean, the numbers are quite eye-watering. I mean, we got a total of 57 cases that we're aware of, and of those, we diagnosed 29 of them. And so, really intensive testing, but a relatively low yield. So we're seeing across the homeless population, particularly in the States, attack rates of 30 to 40%, including very high rates of positivity in the staff. This is a collection of reports on outbreaks. And overall, I mean, in States, in any of the communal shelters, it looked like about 1 in 5 as a minimum were testing positive for COVID. So an incredibly high attack rate in a communal airspace, which basically goes back to prove the fact that, this is droplet nuclei. This is a pathogen that can remain airborne for quite a while, and it's droplet nuclei transmission. So 3 to 4% as an asymptomatic carriage rate in London versus 30 to 40% as an asymptomatic carriage rate in the States has suggested that we, perhaps were reasonably successful in closing down these risk of outbreaks. And I think, the main reason is because we got in there early and we cohorted the population into their own rooms. But I'm conscious of time and I do go on a bit, so I'm just going to summarize with a couple of slides. So, I mean, housing equals health. And as I say, it's been so clear that, the principal determinant of success, in inverted commas, so far in London in particular has been really early cohorting of this population. But this is an unprecedented event. We've had an increasing street population in London for over a decade, the politics of austerity. And everyone's viewed this problem as sort of intractable and unsolvable. It's too complex. And yet within the space of 10 to 14 days, we were able to get thousands of people off the street, out of the night shelters and into their own room accommodation. And at the last estimate, we've got about 5,500 people who are currently in their accommodation. We've tried to use this as an opportunity to make sure everybody can get registered with healthcare services and access primary care. We're currently doing a massive health needs assessment, trying to do as many as possible. Very comprehensive health needs assessment to identify people who are who've got significant unmet health needs, but also to identify people who need what we call shielding. That is, they are still at very high risk of severe disease in the event of a COVID infection, and they are entitled to certain accommodation support. So clinically identifying people who need shielding is a real priority for us at the moment. I've returned to type with my usual obsession with communicable diseases, and so far we've managed to BBV screen, HIV, Hep C, Hep B, TB test, and an STI screen on almost 700 people. And we're just going to carry on with that until someone physically stops us. Another major sort of powerful thing to come out of this was the fact that we now have a pan-London opiate substitution protocol, which is enabling people to get same-day prescribing. We don't want to lose that. This is one of the many things that we want to continue to achieve. We also have had a bit of a digital health revolution in the last few weeks, in that thousands of people have been given mobile phones, and we've been able to use that technology for a lot of phone-based support, particularly mental health support, where there's a huge burden of undiagnosed mental health need in the population. So, the challenges going forward, the earlier policy announcement of everyone in seems to have faded in terms of the enthusiasm to remain in forever. I know colleagues in Dublin and across Ireland have achieved a political coup in getting the government to actually agree to keep people in, which is amazing. We tried to formulate this entire exercise as, the largest housing first experiment ever done on the planet. And, it should have been such, but unfortunately, many of the hotels and the politicians who are paying for this are not willing to sustain that level of investment, and a lot of people are about to be kicked back out onto the streets, and some of them are about to be kicked back out into quite unsafe environments, where, as I say, the risk from COVID remains. We still have, I think, the 5th highest incidence in the world, so there's still quite a lot of circulating COVID in the community in London. So identifying people who really do need long-term protection is a priority. The risk of outbreaks in our population is different to the general population. COVID is going to be a slow, spiky burner amongst the homeless community. And without, a very high level of continued vigilance and outreach and testing, we are going to see, we still have a significant risk of outbreaks in any of the communal areas. And obviously, as you'll all be aware of, we're still in the dark in terms of most of what we know about this pathogen. And that's led to a lot of the poor guidance that's come out so far. Just basically, we don't even know what the infection period is yet. We don't know why there's such a differential attack rate in different populations. We don't know what the impact of wearing masks is. Should we be using masks across all shelters? There's some promising treatment available, but fundamentally, the golden bullet is the vaccine, but that is at least probably 18 months to 2 years away. So we're going to have to learn to live with COVID. I see the priorities going forward as an urgent need to really try and collate our experience and transform that into evidence and use that for advocacy, because there's got flexible long-term policy response, which should be accompanied by clear guidance. And I think that guidance is not that context specific. It should be guidance in terms of a guidance statement for the world, ideally supported by a very human rights approach in terms of the fundamental need for housing in the first place. We're continuing to try and to actively involve the affected community at every level, and we are mobilising a much larger testing workforce as we speak, and that will be principally made up of people who are actually recruiting from the hotels and the hostels. They will provide the service. And then finally, I mean, we should not be limited in our ambition. We should be genuinely pushing for no return to the street, and certainly no return to communal sheltered environments. If we put people back in London into shelters, night shelters, where they are sleeping together in very cramped air spaces, there's going to be a replication of the American experience. And I think internationally we need a consensus that accommodation services, including emergency accommodation services for homeless people, should not be a communal airspace environment. That is a recipe for transmission, and that risk remains large. Thank you very much.
Great, thank you very much. It was incredibly interesting and very. 2 seconds, I'm just going to take back your screen sharing so you can see as well. Incredibly interesting presentation, and thank you so much for being able to kind of tell a story of how everything has evolved, because things have moved so quickly in the last 12 weeks that it can be very difficult to see like what happened and when did it happen. Quick reminder for people to put questions into the question box, and we can put them to Al. I think just to start off, I think it's very clear why America has had a lot more infection rates of COVID-19 amongst the homeless population, because of the communal shelter system, and you were very quick to close those in the UK and create alternatives. But still, like a 30 to 40% asymptomatic rate is very high. Why do you think that is?
I think to a certain extent it's a function of time of testing, because asymptomatic at time of testing doesn't necessarily mean that that person never became symptomatic. So I think the more proactive you are in terms of testing, i.e. if you test a huge cohort, the more likely you are to include people who've got detectable virus but haven't yet progressed to active clinical disease. But nevertheless, there's still, because we've isolated people throughout their illness in COVID care, and we've observed many people who've got, I wouldn't say it's a completely asymptomatic event, but I would say that, within the context of having obstructive airways disease, a few years on the street, the respiratory challenges of crack smoking, heroin use, etc. The idea of a cough in our population is not unusual. We estimate that about 50% of the people we serve in London would meet criteria for chronic cough. And similarly, the actual clinical presentation in terms of a subtle change in sense of smell or taste, etc. A lot of people wouldn't notice that. What we did see in a small subset was really rapid onset of respiratory crisis. So people's oxygen saturating quite quickly, and we needed to escalate people very rapidly for CPAP and intubation. So yes, I mean, one of the reasons why this pathogen has basically bowled us over, I mean, it was a worst case scenario by any stretch of the imagination. We'd never modeled a pathogen like this. I mean, even the international work on flu pandemic modeling had basically looked at the concept of, an attack rate that was, a fraction of the attack rate of this pathogen, and a mortality of 0.001%, not 1%. We know that there must be a significant period of asymptomatic viral shedding with COVID-19, because that's one of its main weapons in terms of having a high attack rate. It doesn't debilitate the host. The host remains circulating and very capable of shedding the virus. And also because of the location where it gets you, it's all upper airways. And so that's why we get this sort of strange change in sense of smell and taste, and we get these sort of strange upper respiratory symptoms. I mean, by the time your symptoms actually manifest, you're probably at peak shed. You're probably maximally shedding virus. So you've reached your maximum infectiousness, as it were, even prior to the onset of the event. This is a clever bug.
I mean, I guess that even makes the reason for closing the common spaces even stronger. So we have a question coming in. As emergency responses are coming to an end and we see the lockdowns are beginning to lift and health has become more prominent on the agenda, how can we better integrate health into any solutions to homelessness?
Well, I mean, the number one priority for us, I think, needs to be to capitalise on the fact that COVID has put homelessness on the map and advocate very strongly that people don't return to the streets or to communal airspaces. I think that should be our united mission at the moment. But certainly in terms of the integration agenda, yeah, 100% agree. There is, a huge opportunity to actually reach people at the moment and address health needs, many of which have been long-term and chronic for many, many years. And similarly, a huge opportunity to think very seriously about being a bit more imaginative in terms of how we manage people with addiction and mental health problems, how we can engage them in long-term support, perhaps even use digital tools in order to do that.
And were there any problems with people who are sleeping rough not giving consent or difficulties with accepting a COVID test or the regular routine that accompanies COVID testing and tracing?
Well, we get really high buy-in. We obviously didn't force anybody to go into the hotels and we can't force people into isolation. We could use a Public Health Act, but what are we going to do with people? I think the entire thing comes down to, working with people where they're at and wherever possible, having quite a strong peer focus. If we send out a load of people dressed up in sort of hazmat suits, it will just freak everybody out. But if we send in, peers with, the right PPE, but people who can have a proper conversation, we still get really good buy-in.
Okay. I think what you've done at least in London, has been incredibly effective. Excuse me, incredibly effective when you look at what's happening in many other countries. And I think a lot of that probably comes down to the fact that you were so quick, like you mentioned there, you were already on this before the stay-at-home mantra was coming out of Downing Street. But if you were to go back and do anything differently, would you do anything differently, or has everything kind of gone quite smoothly?
Yeah, I mean, everyone keeps talking about second wave. Yeah, I mean, I suppose what the name of the game is now is to prevent second wave. Second wave is in hands, it's not an inevitability. We know that there's going to be COVID circulating in populations across the world for the rest of our lives. We know that whilst there's a very high level of susceptibility to this bug in the population, we know that the risk of outbreaks is going to remain very, very high. So we just have to use the evidence that we now have accumulated to inform better interventions to prevent second wave. And if there's one thing I could have had at the beginning, it would have been testing.
Testing.
In the dark is difficult. And as I said, the clinical presentation of this bug is so varied. Testing is where it's at. I just urge everybody to test, if you want to repeat the WHO mantra. That is where it's at.
Okay. Perfect. I think that's it for the questions. I think it's always a good sign of a presentation when there aren't too many questions. It means you've been concise and clear. So I'm going to bring the webinar to a close. I want to thank Al again for joining us and taking the time out of your really busy schedule to come and speak to us. As promised, there'll be a recording. Al, you might send me your presentation afterwards and we'll share it with the participants. And hope everyone has a lovely day. Bye, everyone.
Bye-bye.